Hello. Today we'll be talking about congenital heart disease. Let's begin. So with this lesson, we're going to talk about a few congenital heart defects, beginning with transposition of the great arteries, anomalous pulmonary venous connection. We'll go over double outlet right ventricle. We'll discuss cardiac masses, echogenic intracardiac focus. We'll definitely distinguish cardiomyopathies. We'll discuss pericardial effusion. All of the aortic arch anomalies we'll talk about, abdominal situs, heterotaxy, and then lastly, we will finish with twin-to-twin transfusion syndrome. Let's begin. All right, so there's two types of transposition of the great arteries. You have your complete transposition, which is known as the D transposition, and then congenitally corrected transposition. It used to be known as L transposition, which is level transposition, but now recently it's CC transposition, which you will see in the next few slides. Okay. All right, so with complete transposition, known as D transposition, D as in Dexter, the great vessels are switched with this one. Okay, so the great vessels are switched is commonly seen in males. The four-chamber view is going to be normal. So it's going to appear normal. But when you go to your crisscross, you're going to notice that your parallel vessels, your great vessels are parallel to one another, which you can see in the demonstrations. So you see, instead of they're crisscrossing, they're alongside one another. Now, in your three vessel view, you're only going to see one great vessel, which is the aorta, is usually the one that's present. The pulmonary artery sits behind the aorta, which is not seen in your three vessel view. Okay. Now, these babies are known to be blue upon delivery. Okay. So they need surgery. So this is one of the heart defects that need to be prenatally detected. So then the parents and family and staff can all be on board when delivery happens. So we can avoid having a blue baby. Okay. Now the associated defects with this is VSD, pulmonary stenosis, and then it's also associated with microdeletion of 22 and maternal diabetes. Okay. So keep in mind, complete transposition, great vessels are switched. Okay. Here's an example of that. You see, so both great vessels are parallel. All right. Now with your congenitally corrected transposition, the ventricles are what switched. So it's known as CCTGA. So there's atrioventricular and a ventricular arterial discordance. Okay, it's pretty rare to see this one. It is more common in males. There is a double discordance, so it results in normal circulation. Okay, but your ventricles are switched around. Cyanosis will not occur. It's still important to recognize this, but cyanosis, the babies won't be blue upon delivery. Surgical correction may or may not be necessary, really just depends. You may have mesocardia with this one. The moderator band will be on the left side, but that's because the ventricles are switched. The long axis view of your aorta and pulmonary is going to show parallel. Your aorta is going to be anterior and to the left of the pulmonary artery. And so that's where that L mal position came from, where it used to be called L transposition. Okay. Now the associated defects is AVSD, pulmonary stenosis, Epstein, coarctation, heart block, and again, associated with microdeletion and maternal diabetes. Okay, so here's an example. We actually had a case where we had a transposition congenitally corrected. Now, I wanted to point out, let's first look on the right side. So let's look here. This is the four-chamber view. And it may not stand out for many, but it did stand out for the doctor. And so the doctor noticed that the moderator band was on the left side, which we know this is the left. We see pulmonary arteries and atriums. We see descending aorta. And then you see that how this chamber looks, right? Like, oh, that doesn't look like a typical right chamber. And so that's what caused him to really, really explore more. And truly, he did see that that is the moderator band. And it was confirmed by the cardiologist that the ventricles were switched. Now, do not depend on your auto annotations. Now, it was just, we knew that this was the right ventricle. We knew that, but we wanted to see if the system would pick up on it, and it did not. So do not depend on your auto annotations from your ultrasound machine to label correctly. It's not going to pick up these markers. So we have to be mindful of our morphological markers. The moderator band is a part of the right ventricle. Okay, so let's just discuss normal morphological features. Your right ventricle houses a moderator band. Another thing, the tricuspid valve is going to be a slightly higher apical attachment. It's going to be triangular shape, and it's going to be heavily trabeculated. Okay, now your left ventricle will be conical shape, elongated, which you can see here. Okay, it's apex forming, and it's going to have a smooth surface. So you see the difference. You see clearly this is the left ventricle. And clearly, this is the right ventricle with the moderator band. But in this case, it was switched. So this is an example of a congenital corrected transposition that we found. Okay, so the morphological markers are very important to recognize. All right, so now we're going to discuss anomalous pulmonary venous connections. We're going to start with total anomalous. There's 4 types, okay? So with the total anomalous, supracardiac type 1 is the most common one seen. And so with that particular type, for the pulmonary veins going to connect through a vertical vein to your left brachiocephalic vein, which is also known as your left innominate vein. From there, it connects to the right SVC, okay? And then your type 2, 4 of the veins going to enter into the right atrium via the coronary sinus, or all 4 will enter the right atrium directly. Right? In type 3, confluence of 4 pulmonary veins enter the portal vein. It then connects to the IVC. And then with type 4, it's going to be a mixture of maybe type 2, 3, or type 1, 3. It's going to be a mixture of the ones that we just discussed. Now, some important ultrasound findings. With type 1, the vertical vein will be seen as a 4th vessel on your 3-vessel trachea view. Now, if you took the 3-vessel trachea view lesson, I had some examples on that. Okay, so it's very important to take that lesson as well if you haven't already. So you're going to see 4 vessels in your 3-vessel trachea view. And you're going to have a dilated left brachiocephalic vein because all of that drainage is going through. That's a lot of blood flow from all 4 pulmonary veins. And so that vein, the left brachiocephalic vein, is going to be dilated because of that. Okay. Now, some other ultrasound findings, you're going to have an enlarged right atrium, enlarged right ventricle. Your pulmonary artery is going to be enlarged. Okay. And of course, the pulmonary veins will not be connected to the left atrium. As you see in all 4, they're connected somewhere else. Your septum will bulge into your right atrium because of that heavy blood flow. And then the venous confluence chamber behind the left atrium, which I have an example of that coming up. Okay. So here's an example where you can see where it's dumping into the right atrium instead. And then that confluence, you can see the confluence vein there, the twig sign. All right. Okay, so with partial, it says condition with 1 or more, but not all 4, is connected directly to the right atrium into channels that ultimately drain into the right atrium. So basically, in a nutshell, it says at least 1 pulmonary vein will have a normal connection to the left atrium, and then others won't. but it's different variations, in other words. So it also has 4 types: type 1, 2, and 3, and 4. Type 1, that left pulmonary vein will connect to the left atrium, but the right connects to the SVC. Okay. Type 2, left pulmonary vein connects to the left atrium, right connects to the IVC. Okay. So you're going to have one connected. Here it says right. In type 3, right pulmonary vein connect correctly to the left, but then the left pulmonary connects, it says here, vertical vein to the left, which then connects to the SVC. And then with type 4, the right pulmonary vein connects to the left atrium, but the other connects to the right atrium via the coronary sinus. We have to demonstrate 2 pulmonary veins on every level 2. We have to sample a right and a left. And by us doing that, we are ruling out both total and partial anomalous. Okay, and that's for all of our level 2s that come in. Okay, now it says here it's difficult to diagnose both total anomalous pulmonary vein connection versus partial. So it says here for total, suspect if no pulmonary veins are seen entering the left atrium, or if you see that venous confluence vessel. It says also if there's an enlargement of the right atrium kind of bowing in from that septum. And then it says here, if you find at least one pulmonary vein observed entering the left atrium, then automatically you can exclude total anomalous. Automatically. Because, of course, if one's entering, then that cuts that out. Okay. Now, with partial, the most reliable sign is if pulmonary veins can be seen entering both the right and left atria. That's how you will have to determine to rule out that one. Okay. All right. Associated congenital heart defects with this one is AVSD, TGA, hypoplastic left, coarctation, interrupted aorta, arch, tetralogy, double outlet. A lot of your questions on the exam is going to have a lot of associations. So you have to be familiar with what goes with what usually. Okay. So it says here, approximately 1/3 of patients with a partial anomalous and total anomalous will have additional heart defects. Okay, so it will be other things going on as well. Okay, now let's talk about double outlet. Double outlet right ventricle. This is where a condition in which more than 50% of the aortic root and the pulmonary artery arise from the right ventricle, and almost always a VSD is present. Okay, so basically with this guy, it's a lack of the aortic and mitral continuation. Okay, you won't see that. There's 4 types with this one as well. 4 types. So double outlet, and it's either a subaortic VSD, a subpulmonic VSD, or you're going to have both, or non-committed. Okay. Now, almost always a double outlet right ventricle would be associated with pulmonary stenosis, up to 70%. That's pretty high. And then the other association is coarctation, bicuspid pulmonary veins here, ASD, AVSD, dextrocardia, APVC, right atrial, a right aortic arch, persistent left, hypoplastic right, mitral atresia. So those are other associated heart defects. Okay. Now with far as disease wise for mom, maternal diabetes, as well as 22q microdeletion. Now the best views, basically your apical subcostal 4-chamber is normal because we're talking outflow. So of course the 4-chamber views is going to most likely be normal, but it's going to be when you go to get the crisscross. That's when you're going to see long axis of the great vessel show both vessels coming from the right ventricle. It's going to kind of run parallel. Okay, I have an example. There's some examples here of double outlet right. I personally did see one. I have a clip here so you can see. So this was an example of a double outlet right with a pulmonary stenosis as well as a VSD. Kind of hard to see the VSD, but let me see. But you can see the pulmonary stenosis is here. There is actually atresia because we have some reversal of the blood flow, because the vessel should be going in the same direction, but there is some reversal. So it's atresia, and then double outlet with VSD. Let's watch that one more time. Okay. All right. Okay, so now we're getting to the cardiac tumors. So the most common cardiac tumor is your rhabdomyoma, 60%. Most common number is usually multiple at 90%. I guess you could say the ultrasound feature of it, it's more hyperechoic, homogeneous. Location is ventricle or IVS. Size is variable. You can see either small or large ones. And note cirrhosis, sclerosis, and you see tachycardia with rhabdomyoma. Now they list, you want to just know the difference between all of these. Definitely know the most common, especially teratoma, 25%, usually singular. That's more hyperechoic. I have this diagram here so you can see the typical locations for each one. So it's just, you want to be familiar with this for sure. The least common is the hemangioma, which is at 3% singular, has a mixed texture. It can be located anywhere and variable in size. Myxoma is not usually seen in fetus, but they did mention it. It's singular, hyperechoic with calcifications, left atrium variable. Most of the time it's seen in adults at 75%. And then with fibroma, same thing. Unusual to see in fetus, singular, hyperechoic, or isoechoic. This is known to be in the left ventricle IVS. It's variable in size. Okay. I have an example. Here's an example of a rhabdomyoma that was missed several times actually, but it was then found at 37 weeks. Incidentally, this was found. Let's play that one more time. Very large. It's on that left side. Very large rhabdomyoma. Okay. All right. So we don't really make a big fuss about the EIFs anymore. I remember 10 years ago, several patients will get a amnio. I never seen really terminations from just the EIF, but it was a bit scary back in the days. But now is unless, and when it's isolated, it's like no big deal. So just to mention, it's echogenic intracardiac focus, small discrete structures in the papillary muscles, 90% most commonly known to be in the left ventricle, 90%, but they can occur in the right ventricle or bilateral. It is considered a marker T21 if AMA or other markers are involved. You can definitely consider as a marker, but it's typically not associated with a congenital heart defect, especially when isolated. Right, myopathies, very important. So we're going to talk about the three types. You have to remember their ultrasound significance as well as what to expect far as fetus, because they all mean something differently when you see it. So starting with dilated congestive cardiomyopathy is usually due to a heart arrhythmia, tachycardia, anemia, some kind of insufficiency with the valves, or in utero infection, in utero shunt. Now, the chambers are dilated, which you can see in the example. So when you notice that the chambers are dilated, you want to think infection or congestive heart failure. Okay, so when you see dilated chambers, think infection, congestive heart failure. Opposite of your hypertrophic. Okay, so when you see a hypertrophic, it's usually due to an outflow obstruction, whether it's aortic stenosis or pulmonary stenosis, twin to twin, syndrome, maternal diabetes, Noonan syndrome. Okay. The heart is going to be enlarged. So you're going to have a very large heart. But what else is going to be thickened is the septum walls. Okay. Septum walls will be thick. And when we say thick, it's going to be greater than 5 millimeters. Okay. So when you see that the walls are thick with an enlarged heart, you want to think maternal diabetes or twin-to-twin syndrome if you're in that scenario. Okay. So with restrictive endocardial fibroelastosis, this is either primary or secondary. It results from kind of outflow obstruction, okay, that prevents the blood from exiting the ventricle. So the blood is kind of stagnant. Think of like it calcifies, sit around, so it gets stagnant. So of course, when you think calcifications, you're going to see you see the hyperechogenic areas just throughout. Okay. So if you see this, if you see bright walls, you want to think that there is some type of outflow obstruction. Okay. Somewhere the blood isn't flowing normally like it should. Okay. All right. Pericardial effusion. Pericardial effusion is fluid contained within the pericardium. Has to be greater than 2. Okay. Extend above the atrioventricular AV groove. And studies note when isolated, so nothing else is seen, when isolated, 2 to 7 millimeters is not associated with adverse outcome. Okay. And that's when it's isolated. All right. So let's get into our aortic arch anomalies. Now we're going to start with the right-sided aortic arch. And that is usually due to a regression of a segment of the left fourth arch and the persistence of a right fourth arch. Okay. Now, 28% of the right-sided aortic arch will be isolated. The other 78% will be associated with other defects. Okay. So a bulk of them are known to have other heart defects, whether it's a tetralogy, pulmonary atresia, tricuspid atresia, aberrant left subclavian, vascular ring, double aortic arch, 22q deletion. We're seeing 22q deletion is associated with a lot of these heart defects. I keep seeing that recurring. Now in the sonal view for chamber, descending aorta to the right of the spine, okay, because we're talking right-sided aorta. Normally it should be on the left, but in the cases of this, it's going to be on the right side. Through vessel view, the aorta between SVC and the trachea. Okay, so with right-sided aorta and the left ductus, you're going to have a U shape, which you can see here. Now, in cases where there's a right-sided aorta and a right ductus, it's going to be a V shape to the right of the trachea. Okay, but in cases of right-sided aorta and left ductus, that's where you're going to have the U and then the trachea in the middle. I went into more detail in the 3-vessel trachea view about the difference between the U-shape right-sided aorta and the V-shaped right-sided aorta. So please go back to that lesson to hear that, okay? All right, so with aberrant left subclavian artery, it occurs with right-sided aortic arch, associated with 22q deletion. It's also associated with the vascular ring. It has a low association with VSD and tetralogy, okay? And then aberrant right, that's your ARSA. The ARSA is the most common anomaly of the aortic arch. Have to remember this. Aberrant right subclavian artery, we call it ARSA for short. Okay, now with other findings, it could be associated with T21 as well as 22q11 microdeletion. Okay. Okay, so it occurs with a left-sided aortic arch. You can see the ARSA vessel, which is here, coursing towards the fetus right side. Okay. So here in the sonal appearance, it says your aortic arch view is normal branching. You're going to have a fourth vessel there, though. So it's going to be 4 instead of 3 vessel arising from the aortic arch. The 4th vessel is your Arsa vessel. Okay. I talked about this in more depth in the 3 vessel trachea view lesson. Okay. So this is just a quick review. Now with a vascular ring can be formed either by the aberrant left subclavian, aberrant right subclavian, or if there is a double aortic arch. Okay. Now 10% of these patients will be symptomatic because if it's a tight ring, it's going to have some compression. So it's going to be hard to breathe. Okay, so here's an example of that. All right, double aorta. Now, not to be confused, because you would almost think it's the same, right? Looks the same. With the double aorta, with the double aortic arch, that forms the tightest vascular ring. Okay, so this is the one that's mostly associated with airway obstruction. And what happens here, when we go back to embryology, it is formed by the persistence of both the fourth right and fourth left aortic arch. Okay, so they both stayed. The right side, though, is going to be larger than the left. Right, and the sonographic view or finding is the trident sign, which you can see in the demonstration, the trident sign. Right. So just to look back at the vascular ring one more time, you kind of see the difference there. I can see the difference then when you look here. All right, so now we're getting into our heterotaxy. So once again, we learned that with heterotaxy, it's an abnormal arrangement of abdominal organs, okay? Incidence 1 in 10,000, live births, 42 infants with CHD, risk factors, diabetes, if there's a family relation of mom and dad, it's a high risk of having heterotaxy. The recurrence risk is 5%, okay? And they usually have a normal karyotype. What I've seen from the exam, you definitely have to be familiar with the differences between left isomerism, right isomerism. Okay, so with your left side, you have mini spleens. Okay, you're gonna have congenital heart block, and then you'll have, it says here, heart block with AVSD, 50%. I have it side by side so you can see what occurrence is in relation to the left side versus the right. And what I do, especially when I study, I look at what's different. So right away, we see that the right side has no spleen, where the left side has many. Another thing to set the two apart, you see left side has the heart block, where the right side does not. You see? And then look at, when we go down, look at the common atrium. 80% is on the left. That's rarely seen on the right. So just pay attention to what really stands out, what set them apart. So you can definitely know the difference, because you're going to have a few questions asking as far as the difference. Okay. Same with the interrupted IVC. Mostly seen with the left side versus the right. Okay. All right, so here's that slide again. Remember, we talked about this. So the reliable indicators is the aorta and IVC. Okay, so with left isomerism, you see the two on the left, with right on the right. And then just to recap, situs inversus is the mirror image of normal. Okay, here's an example. You can see the sonogram. So you see aorta without even looking at a caption. You see aorta and IVC is where? On the right side. You see that? Stomach on the left. All right, and then here's a chart that I made. Same thing. It's just going over the abnormal arrangement that you would see far as with the abdomen, and then what's commonly seen far as in the heart views. Please be familiar with this chart. I am happy to send copies of my material to you. If you want a copy, just in the comment section or chat box, I have my email address as well. If you would like to have a copy to study for your exam, so you can have these charts with you. But once again, definitely just pay attention to the differences and similarities, but mainly the differences, because on your exam, you are going to have to point out the two differences, okay? Whether with asplenia, which that's on your right side, or mini spleens, that's on your left, and so forth, okay? They may ask a question like, which one is associated with the interrupted IVC? So we saw from my other chart that that's mainly associated with the left side, okay? Heart block, mainly from the left side. Okay. All right, and then here's just showing examples of the appendages. You can see the difference here, the right and left. Okay. All right, once again. So with this, I had highlighted this for you guys because I wanted to show also about the azygos. So in the demonstrations A, right-sided, you see, so you have the aorta and the azygos. The position of the stomach is in the abdomen is not diagnostic importance in this heterotaxy syndrome. The presence of the dilated azygos vein. So you see the double vessels in front of the spine, and both fetus suggest a diagnosis of left atrial isomerism. So this is something that stands out for that left side. Left atrial isomerism is associated with this azygos vein. And why is that? That's from the interrupted IVC. Okay. The left atrial isomerism and the interrupted IVC, that's where that azygos vein comes into play. We can see. Notice at the bottom, you see them running parallel. See, opposite directions because they're doing different things here. See, the reverse direction of blood flow in the azygos vein. Aorta is heading down. You see, okay. All right, so this is what stands out far as with the left atrial isomerism. All right, and lastly, we're at twin-to-twin transfusion. So what's important, I had a test question that asked me, what is the sign seen for the, or what is seen for, I think it said the recipient twin. I wish I could quote it, but I have it highlighted because I knew that I saw this on my exam. And so you need to know what is usually seen in the recipient twin versus the donor twin, okay? So with the recipient twin, hypertrophic cardiomyopathy is most commonly seen, as well as pulmonary stenosis. Okay, those were the two that came on my boards. Now, with donor twin, rarely you're going to see changes, but if you do, it's going to be dilated cardiomyopathy or VSD. But from what I remember, my exam questions were based off of the recipient twin and what were the changes that you would see in the heart. Okay. I think there was another question that asked, which twin is the most affected, which is the recipient twin, and so forth. And then another question asks, well, what was the association? Which defects were associated with what? So very important to remember, okay? Almost always, most of our monozygotic twins, we automatically do a fetal echo to rule out these changes. And then we follow them until mom deliver. So each time we're looking at the heart. Okay. And let's look at some examples. So here we are. The hypertrophic cardiomyopathy, remember, thicker than 5 millimeters, which we can see. You can also see the progression from 22 weeks up to 35 weeks. See that, A, B, and C. And then at the bottom, it's showing demonstration of pulmonary stenosis. Okay, you see the alienation, turbulence. Notice with the peak systolic volume, it's very high at 200 to 240, very high velocities. Okay. And that is it. we are all done. So next we will pick up with steps side by side. We'll do a fetal echo side by side with our pictures and measurements. And then lastly, we will talk about arrhythmia, which is very important to talk about, as well as embryology. All right. Until then, have a great day.